Osteoporosis. In this section of the audiobook, we will look to unpack in some detail the important aspects of this relatively common condition, and what, as physiotherapists, we should be doing in clinic. It is an important distinction to make at this point that recognizing someone at risk of low bone density, osteopenia or osteoporosis, is very different to recognizing the red flag indications of a fracture, which may be due to that low bone density. In a red flag situation, the recognition of potentially low bone density will aid in your clinical reasoning, but clearly the management will be significantly altered. What is osteoporosis? Osteoporosis is a combination of reduced bone mass and reduced bone quality, which understandably results in an increase in the fragility of the bone structure. Imagine the inside of the bone to be supported by scaffolding bars. In osteoporosis, these bars are fewer in number, reduced bone mass, and individually less solid, reduced bone quality. These changes lead to the bone being at higher susceptibility to fracture, classically presenting as low trauma, such as area of the wrist or neck of femur, or pathological, and sometimes asymptomatic in the spine. Developing osteoporosis is multifactorial. Those starting at a lower level of bone density, and those who are exposed to local or systemic alterations to bone remodeling, are the most at risk. i.e., if you reach a lower bone density level in adolescence, then the normal loss of density as you age will allow it to fall to a level that increases susceptibility to fracture. Or, exposure to something that accelerates their bone loss will achieve the same result. Who gets osteoporosis? Most commonly, osteoporosis follows the menopause, as estrogen has an inhibitory effect on the osteoclasts. Older adults are also commonly affected. As mentioned above, a decrease in bone density is a normal result of the aging process, although not necessarily inevitable. A third category are those with an underlying cause for their reduction in bone density. These are often younger people with a history of nutritional deficiencies, drug therapies, or inherited causes. The prevalence of osteoporosis itself is difficult to determine and likely underreported. However, in the UK, over 1/3 of women and 1/5 of men will sustain a fragility fracture in their lifetime, and at age 75 to 84, the absolute 10-year risk for sustaining a fragility fracture is approximately 24% for women and 14% for men. What should we do? Clearly, in cases of known fracture, especially if it is low trauma, we should be considering factors that may have contributed to lower bone density. We should retain some level of suspicion for all the people who attend physiotherapy and consider if they have risk factors which may lead them to have, or to develop, low bone density. As seen in the above numbers, the likelihood of a fragility fracture is relatively high over a lifetime, so I do not believe it is unreasonable to consider these factors in every person. We will be asking many of the questions as part of a normal assessment, and a process of connecting the dots is not an onerous one. In our younger attendees, recognition of factors contributing to the possibility of low bone density and/or an underlying cause does raise the possibility of more medical emergency. Nutritional deficiencies in conditions such as Red S, for example, or familial history of fragility fractures will raise our suspicions. Investigating. DEXA scanning is the gold standard for measuring bone mass. It is usually easily accessible via a community service, but local pathways will vary. Using a tool such as the FRAX, Fracture Risk Assessment, can help to assess thresholds for investigation. This tool is freely available on the internet. Just type FRAX into Google and you'll find a link for an automated calculator. Management. Medical management through supplementation of calcium and vitamin D, bisphosphonates, and biologics can be used. Physiotherapy has a role using weight-bearing physical activity to load the skeletal structure and in falls prevention. I have more detail on this in the further resources section of the audiobook, where you will find a link to a research review that I wrote, which has some real detail on what we should do with patients and how we should go about doing it.